Welcome everyone to this webinar. I'll just ask that you put on mute if you can. We're recording this on Treaty 1 territory, home of the Anishinaabe, Cree, Oji-Cree, and Dene communities. My name is John McGavock. I'm a settler scientist at the University of Manitoba. In contrast to almost all of our speakers so far, I do not live with type 1 diabetes, but I have a passion for physical activity and type 1 diabetes. And as a member of Diabetes Action Canada Sport Network, I want to describe to you some of the information that has guided me towards down this path and why we're here today. I'm going to start to share my screen. And ask if you can see that and can you hear me? Great. So we're going to go through a couple of slides, but first I'd like to tell you a bit of a story. This is the former president of the United States in the 30s and the 40s. Most of you are aware that a normal blood pressure would be, or a target blood pressure is a systolic below 120, a diastolic below 80. However, FDR's blood pressure in medical records within the White House, from the White House doctor, in 1931, it was 140 over 100. 6 years later, it was 169 over 98. World War I, 188 over 105. And then in the height of World War II, and then the height of World War II, 3 recordings in the course of a year, 186 over 108, 200 over 108, 210 over 112. And in 1945, 260 over 150 before he had his stroke. How come no doctors treated that blood pressure? Because we didn't have the epidemiology to understand what the importance of blood pressure was and the long-term risk of things like stroke or heart attack or kidney disease. And so this reinforces the importance of epidemiology, because a few years later, in a large study conducted in Framingham, Massachusetts, they identified a number of these factors as strong determinants of heart disease risk. So your blood pressure, your body weight, whether you smoked or not, whether you lived with diabetes, and being a man and being older were all significant risk factors, which they were able to identify using, at the time, state-of-the-art epidemiological research. And so what I'll discuss with you today is some of the epidemiology around type 1 diabetes and activity, and give you a sense of where we are and how big some of these gaps are, so that we could maybe fill them as a group of scientists and patient partners, and see these gaps as advantages and opportunities for us to pave the way for new evidence that could guide clinical guidelines for people living with type 1 diabetes in the future. So in terms of blood pressure, the Framingham Heart Study allowed us to understand that there are targets for blood pressure. It also led to a lot of other studies to dial it in for different populations. For people living with diabetes, I think everyone is aware of a target A1C for adults of around 7%, because we know, based on epidemiological evidence, that the risk for different factors or different complications increases with an increasing level of glucose control. Similarly, for blood pressure, I think we're all aware that blood pressure targets are around 120 over 80, and that when you go see your doctor, there's a measurement taken, and depending on your age and your current health, there are different targets for those. But how do we actually know where these targets are, and what kind of evidence is there to put these in guidelines so that they become standard of practice within different clinical settings? In the area of activity, these are the current guidelines. They're a little bit different depending on where you are in the world, but overall, we ask that people participate in at least 30 minutes of moderate activity, at least 5 days a week, so that you can accumulate 150 minutes of activity. More recently, we've actually added this component here of getting at least 25 minutes of vigorous activity a week for a total of 75 minutes. So in the past, we just gave this round number, which was fairly easy, but more recently, data on the intensity of activity suggests that that's also important. Additionally, they also recommend doing a couple of days of strength training for some additional health benefits. Based on more robust epidemiology, we're going into different areas, so including sitting, screen time, and breaking that up. This is a UK guideline. For kids, we're also including sleep and levels of light physical activity. But how do we know this? Are we just making these numbers up? 750 or 75 and 150 are nice round numbers, but where do they actually come from? So most epidemiology and most science starts with a question. And that question has three main variables that make up that question. And ideally, that also comes with a hypothesis. So the three variables that we're going to be focusing on throughout the rest of this lecture are: who was the population of interest that we want to work with? What exposure or intervention are we interested in studying? And what outcomes of interest do we want to measure? So in our A1C question, why do we have an A1C target of 7%? The question could be, among adolescents and young adults who live with type 1 diabetes, if we ask them to tighten up their glycemic control and target a lower A1C, could we prevent things like kidney disease and eye disease? And so I'll just give you an example of how that question was answered. This is probably the most famous paper in diabetes research. It's been referenced over 20,000 times. It's one of the most, so it's a highly cited paper, but it's also probably one of the most impactful studies ever done in the area of type 1 diabetes. Before this study, the target A1C for patients was around 9%. But the question came up from endocrinologists who are researchers of whether or not 9% was too high. And should we lower it? Because 9% really lowered the risk that patients would go low and the risk of hypoglycemic events. But longer term follow-up studies were suggesting that people who had higher A1Cs tended to have higher rates of complications. So their question was, if we recruit adolescents and young adults between 13 and 39 years of age who have low C-peptide suggestive of type 1 diabetes, who have lived with type 1 diabetes for at least 1 year, and they currently have no evidence of cardiovascular disease, if we randomize them to continuing on with their care and targeting an A1C of 9%, or asking them to meet these really tight requirements. So keeping your glucose between 3.9 and 6.7 before a meal, and not allowing it to go higher than 10 after a meal. And then on a month-to-month basis, when you visit your doctor, we're going to try to get you, I didn't realize this till I actually read the paper. The goal was 6.05%. They tried to completely normalize blood glucose. 44% of people in the first part of the study were able to get there, but then they had to let go, and only 5% of people actually made it because the risk of lows was just way too high. I would love to hear the story from the clinicians of how that worked out and why they chose 6. And then they followed people up for 4 years, and they looked at retinopathy, so eye disease, nephropathy, kidney disease, some measures of neuropathy, nerve disease, and of course they measured hypoglycemia. They had to stop the trial early. So for the first 2 years of the study, they targeted an A1C below 7% in the intervention group, and the rest of the group had an A1C in the 9% range, which was conventional therapy. So this was for a total of 9 years. You can see that the target glucose in the intervention group was in the range that they asked people to achieve throughout the day. So these are mean values throughout the day in the early parts of the study compared to those who were in the conventional group. After 9 years, they published their papers. And after that, what's really interesting is they followed everyone up for another 30 years. And obviously after the publication of this, standard therapy changed, and both groups were around 7 or 8% for their A1Cs for the next 23 years of their life. So this is the trial that we're interested in. And for that 9-year window, there was a 2% difference in their A1C. So at the end of 9 years, here's the rates of the main things that they were interested in. So this is retinopathy. This is the group of people that didn't have retinopathy at the start of the study. At the end of 9 years, 50% had some degree of retinopathy if their A1C was 9%. But if they kept it below around 7%, only 10% of the group developed eye disease. So a huge, massive protection from eye disease if you target an A1C of 7%. If you already had some degree of retinopathy, and this was trying to prevent a worsening of retinopathy, it was the same. So even in those patients who had some degree of disease, dropping their A1C to 7% over 9 years dramatically reduced their risk of worsening. So these are humongous effect sizes, showing that you can reduce by 60 to 70% your risk of a major complication by getting your glucose down to 7%. The same thing held true for kidney health. And again, they separated them based on people who had some degree of proteinuria or protein in their urine and those who didn't. And again, the more intensive your blood glucose, the lower your risk for retinopathy. And the same held true for the degree of neuropathy. So again, based on those studies, based on that experimental evidence, it was clear that if you lower your blood sugars, you're going to prevent your risk for complications. And so that's why they changed the guidelines. Really robust experimental epidemiological study. Now, could we do that with physical activity? So why did we get 150 minutes of physical activity? Do you think that we could randomize people in the general population to get at least 150 minutes of activity every week for 52 weeks for 10 years or 20 years, when we know that only maybe 20% of the population currently meets that guideline? Asking people to change their behavior and hold on to that behavior for a 10-year period is very, very challenging. And that's what you would have to do if you wanted to look at how much physical activity someone needs to prevent cardiovascular disease, CVD, or to prevent them from dying. So we don't use a randomized controlled trial. We use a different study called a cohort study. And this is a study led out of Canada that was published in 2018, where they recruited originally 180,000 people. 130,000 of them participated in this part of the study where they filled out a questionnaire about their activity. Importantly, they came from high income, middle income, and low income countries. And they followed them over 7 years to see who died or who developed cardiovascular disease. They recruited people from the general public who had no evidence of cardiovascular disease at baseline and were between the ages of 35 and 70. They filled out a questionnaire saying in the last 7 days, how many vigorous type activities have you participated in? How many moderate ones? And how long did you do those? And then they tracked them over time to see whether or not they had a heart attack or whether or not they died. So in this case, with the 130,000 people, 23,000 of them reported that they did not meet the physical activity guidelines. 50,000 said that they met the guidelines, and 60,000 were getting twice the amount of the guidelines. So these people are getting 150 minutes a week. These people are getting about 300 minutes a week. However, unlike the randomized controlled trial where you have perfect balance between the groups in terms of other variables that could affect your risk of dying, like do you smoke? What do you eat? What is your body mass? How heavy are you? Are you more likely to be a male or a female? In a cohort study, there isn't balance when you're comparing the low activity group to the high activity group. So in the low activity group, there are more, if we look at the percentage of men, there are fewer men in the high physical activity group. So you have an imbalance in males and females. We know that females are less likely to have heart attacks. A family history of heart disease in the low activity group, it's 23%. In the high activity group, it's 35%. So huge differences there. In the high activity group, we had more smokers than in the low activity group. In the high activity group, we had fewer people with diabetes. and fewer people with hypertension. So it's hard to make some of these comparisons, and because these differences exist. And so we have to do some statistical adjustments to make those things balance between those three groups. But using this type of design, you can see that as the amount of activity increases from 0 minutes per week to 3,000 minutes per week, the risk of dying, or the hazard of dying, goes down incrementally. Here's our target of 150, or the current guidelines for 150. And you can see that the rates decrease pretty sharply from 150 onwards, which is why we would target 150. There is some benefit here, even below 150, but you can see that there's, after 150, you're seeing a 10 to 25% lower risk of dying or cardiovascular disease as you start to accumulate more minutes of physical activity. So this is called a cohort study, and that cohort study allows us to pin down the amount of activity that we would want to prescribe to the population so that they prevent cardiovascular disease. There are different types of studies that we can use in epidemiology. We could compare groups at a single point in time, or we can look at just a few cases of rare people who fit within a certain research question. Or we can do two studies that we'll talk about, two designs. One is a longitudinal study where we follow people over time and see who gets disease and who doesn't. Or we can actually run an experiment and do interventions. And that ones that we're going to focus on are randomized controlled trials, because what a randomized controlled trial does is it allows you to get rid of all the imbalances that I showed you before that could occur when we stratify people by a certain condition. It balances those things out. And so using a coin toss to allocate people to the intervention or the control gives you a really robust statistical design to see how well that intervention works. You can go one step further from a randomized controlled trial and pull together data from a lot of randomized controlled trials. So even in the scientific world, you could have a randomized controlled trial that gave you an answer, but maybe that answer came about just by luck. So I always give this example to students. If you and a friend are walking in the woods and they pick up a rock or a snowball and say, I'm going to hit that tree over there with this rock, and they nail it the first time, the first thing we would all say to that person is, oh yeah, do it again. Show me that you really meant to do that. And what a meta-analysis does is it pulls together all those attempts to hit that tree and gives us an estimate of, if you repeated that test 100 times, would you still get the same answer? So the further we go up here towards meta-analyses, the lower the bias and the more likely that what we're seeing is causal. And when we look at evidence and guidelines and the decisions that doctors make around things like activity or A1C, they're relying heavily on these types of studies for their guidelines. And so there's a clear threshold here where we think this is the kind of evidence that we need. Now, just to take a step back, if you've been on the other webinars, we've heard a lot from Jane and Mike and Otmar about different controlled trials. The difference between what they're presenting and what I'm presenting today is they do randomized controlled trials for single bouts of exercise, and they do high resolution, if you will, or really precise measurements of the glucose response to a single bout of exercise. And what I want to focus on here is, well, what happens if we expand beyond a single bout of exercise and go to exercise being delivered over 16 weeks or 12 weeks, 3 times per week, 4 times per week, the chronic effects of exercise or the chronic exposure to exercise. The work that we've heard from thus far is very valuable and very important, and it gives us a sense of how the body responds physiologically to exercise under certain conditions, but it doesn't give us a sense of the long-term impacts of those, or whether or not those effects that those great scientists have seen in their lab, whether or not they can be sustained over weeks or months or years. So we'll talk first about a cohort study. So in terms of physical activity, we typically would recruit large samples of people. So in this case, it could be people living with type 1 diabetes. We could stratify them based on how often they go to the gym. So do you go to the gym 1 day a week, 2 days a week, 3 days a week? When you're in the gym, do you go really vigorously intense or do you go light intensity? Or do you not go to the gym at all? And then compare those groups over time to see, do the high frequent gym people develop higher blood pressure, kidney disease, heart disease, things like that. We could also stratify people just by how much leisure time activity they do or occupational activity. Do you walk to work? Do you bike to work? Do you walk every day? Do you walk 2 days a week, or do you never walk at all? And then again, we would compare those who are on the low end to those who are on the high end and see who gets sick. So here's an example of a cohort study. This is something that we can do within Diabetes Action Canada, where they compared people on insulin pump therapy to those on multiple daily injections, and they followed them for a prolonged period of time. The value of doing a cohort study in this case is that you could get 18,000 people, because all of these people have been registered to see their doctor, their endocrinologist, and their endocrinologist has recorded what type of therapy they're using. And then the scientists mark that down and they compare those who are on a pump to those who are on MDI. They follow them for 7 years to see who developed different conditions and who didn't. The problem with these cohort studies that I mentioned before in activity, so if you're comparing someone who's on a pump to someone who's on an MDI, there are only 2,400 people in all of Sweden who had a pump before 2015 that were included in this data, compared to 15,000. And do you think that the pump allocation was random? Definitely not. So similar to Canada, it'll depend on the policies, the timing of approval of pump use. But pumps are more likely to be used in younger people. Pumps were more likely to be used in women than in men. These are huge differences. There weren't any differences in A1C in terms of pump users and MDI users. But pump users tended to have lower systolic blood pressure, and they were also tended to be more active individuals. So typically this is a comparison that's really not fair. These people who are in this environment were otherwise healthier and probably more affluent than people here. And so doing these comparisons, although it is robust and represents a large number of people, is a challenge to do. And same thing, the pump users tended to have lower rates of cardiovascular disease, lower rates of heart failure, better kidney outcomes, and were less likely to be smokers. So in some cases, the cohort study doesn't always give us what we want because we're comparing apples to oranges. In a randomized controlled trial, we sample a group of individuals. We flip a coin and say, you're going to get the intervention, you're going to get the control. We're going to follow you for a period of time and see what happens. So in our case here, we could say 100 people living with type 1 diabetes want to know the benefits of, or want to participate in a study of physical activity. We give them a personal trainer or a text message that says, please accumulate your 45 minutes of activity every day. The other group, they get randomized to a text message saying, keep up the good work, you're wonderful, and a smiley face, but they don't get physical activity. And then we could follow them up and see, for those in the intervention group that got the activity, did they do better with their time in range with the CGM? Or are they just happier? You know, we could decide what outcome we want to measure. And then we would compare the change in the time in range or the change in happiness to those who got the exercise versus those that didn't. And so those are the two types of designs. Randomized controlled trials are kind of what we call the gold standard. The problem in exercise epidemiology is that exercise is something that a lot of people hate doing. So this is a series, this is a comparison of a number of different randomized controlled trials that used exercise as the intervention and looked at different outcomes. So it could be body weight or fitness or health. They looked at patients living with cancer, patients living with cardiovascular disease, patients living with type 2 diabetes. And then they just measured the overall adherence to programs that lasted over 12 weeks, somewhere between 12 and 24 weeks. I think the average was 19 weeks. And in all of these studies combined, the majority of people only completed 77% of the prescribed exercise. The same happens in drug trials as well. We do know that when we prescribe people drugs, they don't always adhere. But if our goal is to understand exercise and we want 100% adherence to that exercise regime to understand, to answer our question, our scientific question, it's so rare. Look at that. Oh, none of these studies get to the 100% line. There's just handfuls that get even close. So it's got to be a balance. There isn't a right answer here. Randomized controlled trials give us great evidence, but in the physical activity world, as soon as those trials go beyond 6 months, people stop adhering, and it makes it harder for us to answer those questions. So there are strengths and weaknesses in both. The cohort study has issues around natural allocation and comparing apples to oranges. The randomized controlled trial gives you a gold standard. You randomly assign people so you don't have imbalances in your group, but it's hard to get those people to follow up over time. So we need to look at the whole body of evidence from both randomized controlled trials and cohort studies to really give us a good sense of where things are at. And so that's my goal today, is to give you a summary of where we're at in terms of physical activity and type 1 diabetes. This is the connected in motion group. So people living with type 1 diabetes, we want to know if they exercise more, what's their effect on health and cardiovascular disease. This is based on a summary, on a review paper that we published in our lab back in 2019, led by Nika, who most of you know, and now Andrew McIntosh, who most of you should know as well, that just summarized some of this literature. So one of the more recent robust studies on physical activity was very similar to what Diabetes Action Canada is trying to do now. They created a patient repository of people living with type 1 diabetes. They pooled together all the data they had on cardiovascular disease risk factors. And when people were in their clinic, they asked them to fill out a questionnaire about how often and how long were they active in a typical week. And of the 338,000 people from 413 centers in Germany, 18,000 people filled out that questionnaire. And we had data on their A1C, their weight, their cholesterol, their blood pressure, their risk of hypoglycemia, and their risk for kidney injury or kidney disease. In this study, and for every study this group is going to do from now on, this is how they've defined activity. So that you're comparing people who report doing nothing to people who report doing 1 day a week to people who report doing something 2 days or more a week. And across all of these and across different study populations, we see the same type of results. People who, and I'll just give you an example of 2 here, but compared to people who report no activity, reporting more than 2 days a week, you tend to have a lower rate of hypertension, not necessarily in men, but definitely in women. It's evident in younger people, and this group of 30 to 45-year-olds, not evident in 45 to 80-year-olds. If we take a look at BMI or obesity, definitely huge differences in the rates of obesity based on the amount of activity. They also saw lower rates of, or lower A1C, and as well lower rates of kidney disease. So suggestive of a possible benefit of more physical activity on these outcomes. But it's cross-sectional, it's in the same time point, so we don't know which came first, the activity or the chronic condition. So going to a cohort study, the most frequently cited and probably the best cohort study to date was done in Finland. They recruited people approximately 40 years of age who lived with type 1. 2,100 of them agreed to participate in this long-term study. They asked people about the activities that they did in the last week, how often do they do them and for how long. And then they tracked them over time to look at heart attacks, stroke, and the risk of coronary bypass. And so looking at cardiovascular disease, they looked at 3 different elements of activity: total physical activity in a week, how intense their activities were, the frequency that they did the activities, and the duration. And in all 3, they grouped them into 3 categories. In all 4 of these domains, they had 3 categories: low, so you did very little activity, or high, you exceeded the guidelines. You participated in vigorous intensity sport like CrossFit or intense cycling or running. You did it more than 3 days a week, and you did it for more than 45 minutes, let's say. And in all 3 of these domains, the risk of cardiovascular disease was highest in the low activity groups. So the cumulative incidence over 10 years, 11%, 15%, 12% of people developed cardiovascular disease. And that was cut in half or cut in a third if you were in the high physical activity group. And there seemed to be a pretty robust association between the intensity of the activity that you did compared to just total activity or the duration. So intensity seemed to resonate. Interestingly, similar to the DCCT, those who already had some degree of cardiovascular disease, they were less likely to get a second event if they participated in more moderate intensity activity. So again, suggesting more activity is better. They show the same thing for kidney disease. They show the same thing. They weren't able to replicate it for retinopathy, but they were also able to replicate it for mortality. Unfortunately, this is the only really large prospective cohort study that we have. And this is an opportunity for us as a patient partner group to say, how do we collect this data and get representative data in Canada across different age groups? Because really we're basing all of our evidence right now on a small group of individuals from Finland. And so there's a huge opportunity for us to use some tools to capture that. In terms of randomized controlled trials, Jane and myself, when Jane worked in my lab, we published a systematic review of only trials that lasted more than 16 weeks for people with type 1 diabetes. And we looked at an array of outcomes. And probably the biggest thing that we found, there were up to 20, we published this in 2014. There were only 4 trials that had offered exercise for more than 16 weeks. Now, if you take a look at type 2 diabetes, they had 47 trials with 8,500 people by 2011. By 2014, for people with type 1 diabetes, we only had 4 trials with 362. So there's a huge gap in prolonged exercise interventions looking at different health outcomes for people living with type 1 diabetes. The most recent systematic review of clinical trials of exercise, they included all RCTs that offered training for more than 12 weeks. Actually, I'm not sure if it was all RCTs. They ended up with 15 trials. So I think they ended up with some interventions that weren't RCTs. And they looked at an array of things. And they found that in the 15 trials, again, comparing that to what we found in trials with type 2, where we have like 9,000 people, the majority of the trials that have been done so far have been done in adolescents. The mean duration for their systematic review of exercise was 19 weeks. And they offered it between 2 and 3 days a week by and large. For their trial, when they pooled all that data, exercise had no effect on A1C. It had a small reduction in your total daily insulin dose. And the biggest effects were seen in body weight. So people were losing around 2 kilos when they were in the exercise training groups, and they were losing a bit of a BMI. They also saw a drop in their waist or their belt loops. No effect on blood pressure, but relatively robust changes in their fitness. We're interested in, and since that publication, there haven't been that many large-scale randomized controlled trials, except for one that came out last year in 2020 that looked at a high-intensity interval training program, a HIIT, that people did 4 hard efforts for 4 minutes long, 3 times a week, for 12 weeks. They recruited 30 people with type 1 diabetes. On average, they were 40 years old, and all of them had to have a BMI in the overweight or obese range. At the end of 12 weeks, they looked at their time in range, how stiff their arteries were, their blood pressure, a measure of neuropathy, their body weight, their fitness, and again, the risk of hypos. Adherence to a HIIT training program for 12 weeks was only 63%. Right? So now we're down, you probably started at 100%, and by the end it was 50. So people are only doing 1 day a week. So does that really tell us what HIIT does when it tails off like that? In the intervention group, A1C went from 8.6 to 8.4 or 8.1. And then 12 weeks later, it was back up to 8.2. In the control group, it was 8.3 down to 8.2. And this trend was not significant. Time in range was a little bit higher with HIIT, but it also improved in the control group. So there was no difference there. Time in hypos was a little bit lower, but it increased a little bit in both groups. So really no big change there. But really we're not getting, like, these are not really strong clinical trials that would help us guide programs for people living with type 1 diabetes. So based on that evidence, there's this huge opportunity for us across the entire age range to develop clinical studies that would help us understand how much activity do people need for their for a range of different outcomes. So we do have a lot of short-term clinical trials in teenagers, but we have very few in the older age groups. We tend to focus our exercise interventions on people who are not active, but what if we started different activity programs for people that were moderately active? A lot of the work that Jane and others have done in the lab have excluded people who are endurance athletes or high level athletes. And we're just starting to make a movement there to try to understand the effect of exercise on people who are already very active. We could focus on cardio or aerobic exercise. We could focus on resistance or a combination of the two, like CrossFit, or we could just look at moving people from not getting any activity to just starting to walk to work. And there's a huge opportunity for us to use CGM data to take a look at the impact of exercise on a wide range of all the variables that come out of your CGM. We can also take a look, we have very little clinical trial evidence for the effect of exercise on risk factors for cardiovascular disease, and even less on mental health and mental well-being. And if we take a look at what people with type 1 diabetes are interested in, I'll just skip to that. The number one outcomes that came out of the Irish group that we learned from at the beginning, they want to understand how exercise or how interventions improve your diabetes-related stress or burden, your diabetes-related quality of life. How does exercise improve other aspects of self-management behavior? And then again, the typical things, DKA, A1C. But a lot of these core outcomes that patients want us to see, we haven't included in any of our trials. So with Nika's help, we've published, and with our patient partners here in Manitoba, we published a top 10 list of areas that we want to tackle in the area of exercise and type 1 diabetes, and that's going to guide us moving forward to develop really robust trials to try to answer some of these questions. This is our path here, and I want to thank Conrad for developing this infographic. We're going to take these priorities. We're about to launch our discrete choice experiment to try to understand preferences for people so we can maybe improve that adherence level because it's already low for people who are enrolled in clinical trials. We'll get a sense of what worked for people who are already active by interviewing them and saying, what did you do to be active? How have you maintained it? What would you teach others or tell others to do who want to be active? And then work together with people living with type 1 diabetes and scientists to design the future of clinical trials so that we can address this massive gap in the clinical trial space. And one of the things, and I don't know if we have a ton of time, but within Diabetes Action Canada, we have a huge opportunity now to start to leverage smartphone data, wearable data. So we can record a ton of data from our smartphone. CGM or pump data could be integrated already. If we could move that or link that up with accelerometer data for steps, time of day, intensity of physical activity, and then just like Diabetes Action Canada is doing, link that to current electronic medical records, we could have huge samples of individuals that have tons of physical activity and health related data, and potentially some of the diabetes related outcomes that people are are interested in, and we can develop really robust evidence to inform guidelines around physical activity based on these approaches that are available to us. So that's it for me. Thank you very much for listening. And if you have questions, you can email me, you can visit our website, or check us out on Twitter. And thank you very much. I'll stop sharing my screen. Questions, comments?
You got a lot of radio silence. I'm wondering if you want me to jump in with the repository.
Yeah, sure. So maybe Conrad, you could jump in and tell us what Diabetes Action Canada has done in terms of the repository and maybe some of the projects that are starting to emerge from there.
Yeah, perfect. I'm going to throw up a very quick slide deck that I just created yesterday. So good timing. So very quickly, National Diabetes Repository. What is it? So what we basically do is we got patients involved to co-create a platform that brings in EMR data, put patients at the forefront of research and answer questions that matter most to those with diabetes. How it works, we're going to start off with the star right here. We collect data following privacy legislation. Family physicians permit their clinic's EMR data to be used for research, and patients have the option to opt out of sharing their data. All data is de-identified, stored in a centralized computing environment. We move here to the governance section. Research proposals are reviewed by a scientific advisory committee and research governing committee. The committee is made up of 50% patients. So patients here have a direct say in the types of research work that gets done. Access is provided with REB approval for every single research project. The analysis, researchers have access to the virtual environment. A project-specific data cut is provided to them, so they only get the specific data that they need to answer the question that they're asking. Before any research outputs get created, we run a risk of re-identification to make sure no patient can be identified. And then finally, knowledge transfer publications come out of it, and patient partners will be given authorship based on international authorship guidelines. So where is it? So it sits right now at Queen's University at the Center for Advanced Computing. I won't go into the technical details, but I will tell you this is how we get the data. So de-identified EMR data is provided by consenting physicians from regional practice-based research networks. Data is all encrypted and de-identified, and then provided to the National Diabetes Repository. This is what it looks like right now. So if we look at total number of patients, we have data from Quebec, Ontario, Manitoba, Alberta, and Newfoundland, just under 150,000 patients. And this is a split between type 1 and type 2. We also have a non-diabetic cohort group of 150,000 patients, which is age and sex matched. This is what it looks like, almost a 50-50 split with male and female, over 10 million prescriptions, just under 35 million lab tests. Lots of data. I'm not going to get into it, but we have lots of data. What do we want to do? And I think this is where it actually helps. This is a future vision. We want to translate research findings into insights. Predictive analysis, who's going to develop a complication? How can we actually inform their physicians? And this, I think John can actually fit in because we have the opportunity here to look at all the data to say, okay, who actually meets that criteria to be part of an intervention trial and study? Even though the data is de-identified, we do have the opportunity to identify potential participants, inform their family physician. Family physician can actually offer them to be part of the trial. And then continual monitoring, self-management, and access to a virtual care platform. Software environment, this is what we have. This is what we provide researchers. Whole bunch of stuff here. We're focused more on AI right now, so risk calculators and risk predicting algorithms. And this is our servers up in the cloud. So it's somewhere up there. It's an actual picture of it. We sent a chopper to get that picture, but this is basically what it is. So lots and lots of data, but we do have the opportunity, I think, from a clinical trial perspective to offer researchers a chance to get in touch with AI, with patients who can participate in their study. So that's it in a nutshell.
And the other thing that I think is attractive is because it's linked to primary care data, if we could people are already wearing devices, we can start, prospectively thinking about linking your wearable data to that EMR. And I'm not sure if anyone's done that. I know there was discussion about using the BANT app and trying to link that. I don't know where we're at there.
There is. So BANT has the opportunity to collect it. The issue we're going to have is because we have de-identified data, we can't necessarily link those who download the BANT app to our data. But we have worked with Dr. Karen Cross out of the Hospital for Sick Kids, St. Michael's Hospital, where she's looking at a lower limb amputation and the prevention, limb preservation. She created a device which takes high resolution images of a person's foot, so the actual vascular composition. We provide that to family physicians. Family physicians give this handheld device to patients and record the EMR ID number of the patient on it. So all this data can get captured in the repository, and we can link it by the EMR ID of the patient. So we know who the patient is without knowing the physical identity of the patient. So it's possible.
Cool. Very cool.
Sorry, I got a little one here. This is my type 1 hero right here. So for those of you who don't know, this is Chloe. Chloe has type 1 diabetes. She got it shortly after I joined Diabetes Action Canada, and she's showing you her Dexcom.
There you go. Hi, Chloe. The beauty of doing Zoom at home. So yeah, I think this this kind of evidence and the lack of or the opportunities for data collection and for interventions is huge. And so hopefully when we move into our hackathon, we can start to pull together some of this information and come up with some more novel but high-powered studies that could help us dig into some of those questions that our patient partners are interested in tackling.
Have you given thought of how you're going to recruit the patients into the trial?
Well, we've just signed up for the first, we're one of the first connected T1D. So hopefully people here have seen Connected, and if not, I can send it around, but it's a registry where we're going to map participants to research studies. So we've signed up for our DCE. We're putting that up there. And so that's probably going to be the first place. And then our connections with other patient partner organizations like Connected in Motion and regional groups affiliated with Diabetes Canada. So that's kind of the plan, but DAC has been a huge resource for us in terms of connecting people across the country. So with that, I'm going to stop recording, and we will see everyone next week. Hopefully it's going to be 9 o'clock. Pediatric endocrinologist who lives with type 1 diabetes will be talking about her experience doing hackathons and how they've done it across different platforms, focusing on different areas: diabetes related research, diabetes related technology, and more importantly, supporting people during COVID. So how they've used hackathons to improve care during the COVID era. And it'll really help us dial in what we're going to do for our hackathon later this spring, early summer. So hopefully you'll be there. And again, for those who are on, this will all be posted on our webpage, diabetesactioncanada.com, under webinars and exercise. So if you missed the last ones, or if you're going to miss next week, everything will be posted there.